All right. Good afternoon, everybody. I'm Jay Chhablani from LV Prasad Eye Institute. Thank you very much, Dr. Girdhar. It's an honor to be part of his IC, and I find it very unique because none of the speakers are talking about the trials or the Lucentis or Ozudrex. So it's a very unique IC. So my topic is very challenging in terms of there will be a lot of overlap with the previous speakers or even the forthcoming speakers, but I have tried to uh, localize myself only in the central cyst area. So let's see what are we are going to see in forward slides. So I'm just going to brief you about the types of DME, how do we actually correlate the fluorescein with the OCT, and what actually we evaluate when you look at the any cystoid macular edema and pathological changes which it actually causes, and what are the clinical effects of these cysts and the treatment of cystoid macular edema. So these are the typical slides. We all have seen that this is a spongiform thickening, and you have these cystoid changes in the fovea, and then you can have a serous detachment, which Dr. George has already covered, and you can have some vitreomacular traction as well. So let's see how do we actually look at the cystic spaces on fluorescein and on OCT. So before the OCT came, this terminology of a petaloid pattern was very well established in terms for fluorescein angiography, and fluorescein was considered as the investigation of choice to look at the petaloid pattern. But since we have now OCT, so there are many studies which have clearly shown that these cysts can be seen much better on the OCT compared to the fluorescein. So right now we consider OCT as our investigation of choice when we really want to differentiate the types of edema or specifically on cystoid spaces. But more interestingly, I came across this paper from Japan which actually brings up this typical picture of a fluorescein. So if we look at this fluorescein picture, what we are seeing is the central part is the typical petaloid pattern which we all have been seeing for ages, and here you have a honeycomb pattern. What they did, they actually correlated these two types of pattern with the OCT, that the petaloid pattern in the center was primarily due to these large cysts which are in the outer part of the retina, and this honeycomb pattern which is in the peripheral part, that is parafoveal area, which actually correlates well with these INL cysts, inner nucleus cyst. So this could be a very interesting way of looking at the cystoid macular edema in diabetic cases. So what do we actually look at the cyst when we have a patient with cystoid macular edema? These are the couple of things you would be looking at. What is the size of the cyst, where these cysts are located, what are the hyperreflective dots if it has an optical reflectivity, and the most important for us to prognosticate whether it is a recent looking cyst or a chronic cyst. So there are many studies which they have tried to classify what are the size of cyst, but just to give you a brief idea, when we say a mild cyst, we usually talk about these cysts which are actually in the inner nuclear layer. When the outer layers are affected, especially the outer plexiform layer, you will have an intermediate or a moderate to large size of cyst, which are actually much more dangerous to the outer retinal structures. So about the hyperreflective foci, Dr. George has shown a very interesting studies. Just to brief you up, that these are the hyperreflective dots which you should be looking at. They are usually present near the base of this cyst, involving the outer part of the retina. As Dr. George already mentioned, that these could actually be a sign that you really need to hurry up the treatment, because they are, once you start the treatment, they are actually sometimes they go and sit subfoveally. So this is the situation where you can actually prognosticate. I usually tell the patient that, okay, I'm starting the injection, the swelling is going to come down, but these all white dots are going to sit at the fovea, which we really don't have any control, and that could be the cause of your vision loss. So most important slide for all of us, how to actually look at the cyst and decide whether it is a recent cyst or a chronic cyst. We really don't have any clear-cut studies. This is just our assumption that this is a picture of a recent cyst where you can see the retinal structures are seen clearly, but you have some cystoid edema. But when you look at these top two images, you can see that actually these large cysts have coalesced together. There is already, these are supposedly the Muller cells which are actually seen very clearly, and these cysts are becoming large and large. So when you see a picture like this, that means the patient has a very poor prognosis. Even if you flatten the retina, the patient is not going to have much improvement. But more importantly, we need to look at the outer retinal structure, which I'll be coming up in my slides. So another interesting thing is the optical reflectivity of the cyst, because many a times there could be some confusing pathology, like Dr. George was mentioning, that by looking at the cyst, you can actually suspect what could be the actual cause of this edema, especially when you have to differentiate sometimes the pseudophakic and a diabetic macular edema. So in case of diabetic macular edema, these cysts have actually a slightly hyper-reflective content, which could be the sign that, okay, this could be more of the proteinaceous material which is actually accumulating in these cysts. What these cysts actually cause, let's look at the pathological implications. The first effect what these cysts can cause is the photoreceptor damage. There could be, these are just the theories, that there could be a degeneration of the neuroglial component because of the large size of the cyst. They are actually compressing these cells. They are causing lateral compression as well. And this could be related to the duration of or the severity of the cystoid edema. So these are the couple of pictures which are showing that these are the large cysts. If you look carefully at the outer retinal structure, you have some damage. So you realize that, okay, if the cyst is large, we can't actually leave it like this, because eventually, because of the compression, they are going to cause the damage to the photoreceptor layers, which will eventually going to cause poor prognosis. If you look at this picture of a moderate size cyst, you still have the outer retinal structures intact. If you treat this patient quickly, he is going to get benefited, and this benefit is going to stay much longer. There is a theory that, okay, you have a cystoid macular edema. Does it actually correlate with macular ischemia? So these cystoid macular edema, the cystoid spaces on the OCT have been correlated with the foveal avascular zone on fluorescein angiography, and it has been found that you can have a microaneurysm at the junction of this FAZ, which could be related to a macular ischemia. Again, why it happens? It could be because of the compression of the surrounding tissue, or because of the neuroglial degeneration. There could be a paucity of the growth factors. Let's look at this image from one of the papers from Japan, that you see they are showing these cysts are present, and this is the early phase of the fluorescein, where we can see that the FAZ is slightly enlarged, and you do see some microaneurysms at the junction of the FAZ. If we look at the much larger cyst, which is obviously a chronic looking cyst, but now you look at the fluorescein angiography of this patient, you are seeing that the FAZ is much more larger. It is not necessary that this has happened because of the cyst, but it is a good way of looking at the fluorescein and correlating with the OCT and trying to understand, okay, what are we dealing with, whether there is a foveal avascular enlargement or not. What are the clinical implications of these cysts? So we all know that, okay, when you have cystoid macular edema, there will be a severe reduction in visual acuity, and studies have shown that these cysts also respond very poorly to our conventional treatment. So what are the effects on microperimetry? Because many a times we don't understand what is the actual damage it has caused. So the microperimetry is something really useful, which gives you the idea that, okay, these are the black dots which are showing that the sensitivity has significantly decreased. And you can see these cysts are much more larger in this patient. And there are studies which shows that if you have larger outer nuclear cyst, you can have the reduced sensitivity on microperimetry. We just performed a study in which we actually calculated the cyst volume in the whole macular cube area and correlated it with microperimetry, and we actually did not find any relationship of this cystoid space volume with the visual acuity or with the retinal sensitivity. However, in this study, we did find that the cystoid space optical intensity, the reflectivity, had correlation, as I was saying in my previous slide, that it has a very clear association. Just last, that, okay, you have a tractional edema. We all know that this patient is not going to benefit with injections. This patient has to undergo surgical management. Just to conclude that, okay, what are we achieving by looking at these cysts? We can actually predict the treatment outcome by looking at the OCT to understand whether it is a recent or a chronic cyst, how is the photoreceptor status along with this cyst, and if there is any presence of traction or neurosensory detachment. Just a last slide on treatment options, that we all know that we have these options, but in my opinion, in my cases, I prefer to take steroids. If I see a large cystoid, then I prefer to give Ozurdex injection, because in my experience, it really works really well for edema, like Dr. Girdhar sir showed. All right, thank you very much for your attention.